Welcome, everyone. Thank you for joining today. My name is Max Hadler. I'm with Physicians for Human Rights, and I'll be moderating today's press conference. With us today are four of the world's leading experts on global health. They'll share insights and perspectives on global COVID-19 vaccinations and the actions that high-income governments need to take now to save lives and end the pandemic. With the UN General Assembly underway and Wednesday's global COVID-19 summit approaching, their expertise could not be more relevant or timely today. You'll hear brief remarks from each of them before we turn to questions from the media here today. But first, a word about why I am here today. I represent Physicians for Human Rights, a health and human rights organization that believes if people can't access the vaccine because of where they live, the world will fail to uphold the human right to health and continue to imperil the lives of millions of people. As we have seen again and again, this virus respects no borders, and if COVID rages in one part of the world, further spread and new variants threaten us all. We also see vaccine access and equity as human rights issues, and right now the world's vaccine hoarding powers are failing to meet their obligations to the right to health and prolonging the pandemic for everyone. I'll offer a few key statistics to start off on current inequities and to frame today's conversation. Of the nearly 6 billion COVID-19 doses administered to date, only 0.4% have been in low-income countries. 80% of shots have been given to people in high or upper middle income countries, many of which have now launched booster campaigns, while frontline healthcare workers and immunocompromised people in low-income countries have yet to receive a single dose. From both a human rights and a public health perspective, this staggering inequity is unconscionable and it is untenable. We're glad to see President Biden convene a global summit and publish targets, but what we need now is action, not more unfulfilled promises or hollow rhetoric. Let's look at the track record. The US has committed about 600 million doses, but delivered less than a quarter of them. EU members have delivered 18 million of the 200 million doses committed to date. The last time there was a major meeting of world powers to commit to vaccine donations was at the G7 in England in June. Only 1 in 8 of doses promised at the G7 have been delivered. And meanwhile, these same countries are slated to waste 100 million vaccine doses this year. Even with improvements, donations alone are not going to be sufficient. And high-income countries have demonstrated no real willingness to push pharmaceutical companies to share vaccine know-how and transfer technology. There's been minimal progress on waiving intellectual property rights around vaccines and nothing concrete on either of these important tactics in the White House's global summit targets. At PHR, we're pushing the US and other wealthy governments to do more. We do so as part of the People's Vaccine Alliance, a coalition of more than 75 organizations advocating that COVID-19 vaccines be available to all, everywhere, free of charge. Our movement is calling on high-income countries to invest immediately in increasing vaccine manufacturing and delivery systems, to require pharmaceutical companies to engage in tech transfer related to COVID-19 vaccines, to forcefully endorse a temporary waiver of intellectual property rights on COVID-19 vaccines, and to equitably reallocate doses that have already been purchased based on need. With that, a few quick logistics for members of the press who have joined us today. Please feel free to write questions as we go for the speakers using the Zoom Q&A box during the opening remarks that each will provide. And then after the four speakers have concluded, you can use the raise your hand function and I'll call on folks for their questions, or you can continue to type your questions into the Q&A box. We're going to do our best to get as many questions answered as we can in the hour that we have scheduled for today's conference. And if we don't get to your question, or if you'd like to follow up with any of the speakers in the coming hours or days, you can write to media@phr.org and we'll connect you. Okay, I'm really pleased to introduce our first speaker, Tom Frieden, CEO of Resolve to Save Lives and the former director of the US Centers for Disease Control and Prevention. I do want to note before I turn it over to Tom that he's only with us for the first 30 minutes today because of scheduling constraints. So please submit questions for Tom into the Q&A box if you have them. Tom, the floor is yours.
Thank you so much. Thanks to PHR for highlighting the crucial need for global vaccine equity. It's great to share the virtual podium with my longtime friends, Dr. Swaminathan, Dr. Joia, and Salim from South Africa. So it's great to be with you all, Salim Abdool Karim and Joia Mukherjee. The bottom line is that we're in a completely unacceptable situation. Less than 4% of Africa's population has been fully vaccinated. millions of healthcare workers around the world are facing significant risks from COVID, despite excess vaccines in many high-income countries. At the current rate, much of the world could remain unvaccinated and global stability out of reach till 2023 or even 2024. There's a myth that there's a glut of vaccines coming in 2022. And you can see that myth promulgated by vaccine manufacturers and ill-advised journalists. Boosters, the possible need for tweaked vaccines for variants, the need to revaccinate people who may have received less effective vaccines, production failures make a multi-billion dose shortage all but inevitable in 2022. We have to rapidly scale up production and distribution of effective vaccines to all countries, regardless of income level. The virus that causes COVID doesn't check your bank account. Equitable vaccine distribution isn't just the right thing to do morally. It will also allow the world to resume travel and trade faster, to reduce political instability, and crucially important, to reduce the risk of emergence of even more dangerous variants. All of the effective vaccines need to be scaled up, but the mRNA vaccines are a particularly promising tool. It's a stunning victory for science and humanity against the deadly virus. They are frankly safer and apparently more effective than other vaccines. They're also able to be scaled up faster and less expensively. They require less infrastructure, and they're less susceptible to production delays and problems. The billions of vaccine doses needed could be produced rapidly, and also mRNA allows vaccines to be tweaked for variants, which is the biggest wild card right now. Fundamentally, they are the world's insurance policy against production failure and variants. It's ethically imperative, epidemiologically essential, and economically crucial that we transfer mRNA technology to manufacturing hubs. This is crucial. Establishing distributed mRNA vaccine production hubs is a train-the-trainer approach. It's a regional approach that can serve as a regional resource. I believe that it needs to be combined with very strict licensing and quality controls that will protect the intellectual property investments and ensure vaccine integrity. In this way, the need for new vaccine clinical trials would be avoided, saving many months. And it's possible to accomplish all of this within 3 to 6 months if vaccine originators share their technology. Fundamentally, we're allowing 2 companies, one of which the US has substantial authority over, to hold the world hostage as they prioritize selling high-cost vaccines to rich countries and do little or nothing to scale up to cover the global gap. And let me mention that the CEO of one of these companies has had the gall to suggest that countries in Africa won't be able to use vaccines. This is reminiscent of the racist language that was used in the 80s and 90s to say that African countries wouldn't be able to use antiretroviral drugs. And just as we see actually a higher adherence to antiretroviral drugs in Africa than in the US and many other countries, many of these countries have excellent vaccine distribution systems that can surpass in efficiency and reach what the US reaches. We need a 3-pronged approach. First, expand the current partnerships, for example, with Moderna and Lonza. Second, establish vaccine production hubs in the US with willing other manufacturers with tight controls. Third, have global hubs as well, starting perhaps with South Korea, which is ready to do this and which there's a commitment since May of last year to do that with. It will be important to ensure that there is fair compensation, indemnification, and allowance of the originators to benefit from any tweaks to the production process. But don't believe these companies if they say it'll be a year or 2 to scale up production. It took 3 to 4 months for Lonza to begin producing. Finally, I'll just say that we don't need more meetings. We need billions more doses to prevent millions of preventable deaths. We won't end the pandemic until the world is vaccinated. And though we can't rely on vaccines alone, masks, testing, and other measures will remain important, vaccination is our most powerful tool to prevent deaths, preserve healthcare, and reduce spread. Thank you.
Thanks so much, Tom, for those really, really important messages, and also for drawing some parallels to previous experiences in global health that I know many of our colleagues on the line today have been a part of. Our next speaker, I'm very excited to introduce and to be on the same stage again with Dr. Soumya Swaminathan. She is the Chief Scientist at the World Health Organization, a champion of global vaccine equity, and I'm excited to turn it over to you, Soumya.
Thank you, Max, and thanks very much to Dr. Frieden for laying out the issues so compellingly and comprehensively. And in fact, his remarks reminded me of the time way back in the late 90s and early 2000s when I was working with HIV and TB patients in Chennai in India. And my patients would ask why they could not access antiretroviral treatment when they had heard, and they could obviously read in the media and see on television, that people in other countries had access to these drugs which could keep you alive, whereas here it was a death sentence. And I really had no answer at that time to give my patients, and it was a dreadful time, and all of my fellow panelists have been through the same and similar experiences. This is, and AIDS is not the only disease, by the way, for which we've seen this happen. We've seen it for something like hepatitis B vaccine that is a lifesaver and prevents people from getting chronic liver disease and liver cancer. It was available in high-income countries about 30 years before it became available in low-income countries, and that was thanks to Gavi, that many of these vaccines are now available in countries where they would not otherwise be. So this is the reason why the WHO and Dr. Tedros really took the leadership way back in April of 2020, long before we had any vaccines at all, or we even knew that we would have safe and effective vaccines or drugs to treat COVID. But the ACT Accelerator and the COVAX was set up with really two goals in mind. One was to bring all the partners together, whether they're global health institutions, private sector, public sector, governments, civil society, to accelerate the development of new tools, new virus, so you need new tools. That includes diagnostics, drugs, and vaccines. But the other equally important goal was to ensure fair and equitable access once these tools were developed. And so we started working on things like a fair allocation process for vaccines when they eventually become available. While at the same time, we were working through the R&D blueprint and colleagues around the house on really trying to promote the development of these tools, essentially by doing some of the normative work that's needed, doing things like target product profiles for diagnostics, for vaccines, setting benchmarks, which then regulatory agencies around the world also adopted in terms of what the efficacy and the safety benchmarks would be, working with regulators through the International Coalition of Medical Regulators to ensure that there's harmonization. And then COVAX itself has done a number of things for the first time globally, including setting up a no-fault compensation system, which basically deals with the issue of these rare serious side effects that can happen when you're using new vaccines on a large scale, and ensuring that countries didn't have to go one by one entering into these insurance policies. We set up indemnification and liability language, which all companies would agree to. We had advanced purchase agreements with a number of we had 10 vaccines in our portfolio. What we didn't have, I guess, was a lot of money at the beginning as we were still fundraising. And this was the time when many high-income countries were making their advanced purchase agreements. Anyhow, when one is dealing with a pandemic, I think the bottom line is that you have to have this global solution. I mean, I think science has delivered, technology has delivered much more than we could have expected, whether it's the whole genome sequencing that's tracking variants, or whether it's all of these different vaccines that we have today and more in the pipeline. that we're also supporting because we do need more vaccines. But I think the issue is that a country by country approach, a nationalistic approach, is not going to get us out of this pandemic. And that's where we find ourselves today. And this is the reason why the WHO and everyone, a lot of other agencies, Gavi, obviously, CEPI, just heard Dr. Frieden calling for a few things to happen right away. One is to share the excess supplies with COVAX, because we know many countries have more than enough supplies. The second is, especially those countries that have vaccinated a large proportion of their population, but are still stockpiling supplies in case they need to give boosters or in case they need to use it next year. This is actually the time to prevent deaths. And today, the statistics are that we're still averaging about 4 to 4.5 million cases a week around the world, and anywhere between 7 to 10,000 deaths. It varies a little bit, 7 to 10,000 deaths a day. So we're averaging 60 to 70,000 deaths a week. These deaths are all preventable because we have the tools now. And it's unacceptable that we should stand by and accept the fact that 8 to 10,000 of our fellow human beings will die because we cannot get the vaccines to those countries. As you heard, most African countries have vaccinated less than 3 to 4% of their population. This doesn't even begin to cover the vulnerable groups. So urgent need for redistribution of supplies to Africa and other countries that have vaccinated less than 10%. We have these goals that we've called for 10% of every country's population by the end of September. We're almost in end of September now. We're going to miss that. 40% of every country's population by the end of the year, and then going on to cover the adult population of all countries by the middle of next year, or 70% on average. But to do that, we need action now, not next year. We have to prevent deaths. And so sharing vaccines. And then finally, I would say the manufacturing technology transfer is really, really important, and it can happen. I think all it needs is a will. The WHO is willing to support any company that's willing to do a tech transfer of their proven technology, particularly mRNA, because it can be done very rapidly and it can be quickly tweaked to deal with variants or other pathogens. And we've set up an mRNA technology transfer hub in South Africa. It's ready to receive the technology, ready to transfer it to others. And this is the time actually to make that happen. And as Dr. Frieden said, it can happen. If there is a tried and tested technology with expertise that comes in 6 months, we should be able to have a couple of facilities producing additional doses. This is going to go a long way to vaccinating the world's population. Stop there, Max.
Thanks so much, Soumya. And before I turn it over to Dr. Mukherjee, I just want to jump in. We've gotten quite a flow of questions and want to make sure that Tom and Soumya have a chance to answer before Tom has to drop off. We have a question from Cheryl Stolberg at the New York Times relating to the likelihood that the US FDA will authorize boosters for those over the age of 65 or at high risk of severe COVID-19. And so the first question is, do you believe that the doses for those people who are likely to be approved for boosters should instead be used to vaccinate people in poor nations who have limited access to vaccines currently?
Max, after Tom, maybe.
I'll say I can try to stay on till after 2 o'clock so that we can get to the other speakers without delay. And I did answer online, but fundamentally, vaccine nationalism is both ethically indefensible and politically inevitable. There's limited evidence of the need for and benefit of a third dose, although from a US perspective, it's sensible. You have evidence of waning efficacy against infection and the theory that that will predict future waning against severe disease. Not entirely clear that that's the case, but if you wait for the nursing home population, for example, you may see a big increase in deaths. So I don't think it's an unrealistic or an unreasonable recommendation. But if you look at the bigger picture of where we are in the global pandemic, it's horrific. This is a horrific moral and epidemiologic failure. Soumya?
Yes, I mean, I think we're reviewing the data very carefully as well. And we just had a recent global consultation on the need for boosters. And certainly once the data starts telling us who's going to need boosters, at which time point, what doses, at what dosage, at what intervals, this will be something that WHO will make recommendations on. But as far as the science is concerned, I mean, it's still evolving, it's still early days, and it's too soon. Really, there isn't enough evidence from enough countries around the world to suggest that the vaccines are indeed failing in terms of the main goal of the vaccines are to prevent severe disease and death. The main goal is not to prevent infection, asymptomatic or mildly symptomatic infection, which would have been wonderful if that were to be the case. But I think for the time being, what we'd really like to do is prevent severe disease and deaths around the world. And all the vaccines are doing that at this point. All the WHO, UL vaccines are doing that. And even against the Delta variant, they continue to be highly effective against the severe manifestations of the disease, which is why we believe that using those vaccine doses, and we do have limited supplies of vaccines, as Dr. Frieden said, it's a myth. When people say we can do both, unfortunately, that's not true, because at the moment we are in a zero-sum game. Vaccines used in one place will have to be necessarily taken away from some other place. And so this is the time to provide the primary course of vaccination to more people, at least the vulnerable around the world. And then meanwhile, accumulate enough data about the boosters to be able to use, if we have to do boosting eventually, which we might need to in some groups of people, but do it in an informed way. Thanks.
Thanks so much for that. And I think we can talk some more in the process of answering additional questions about how to get away from the current situation of being in a zero-sum game, because I think that there are solutions for that as well. So we will have plenty of time for questions in a bit, but I want to now turn it over to Joia Mukherjee, who is the Chief Medical Officer at Partners in Health, which in addition to all of the amazing service they provide is also a partner of ours in the People's Vaccine Alliance and many efforts. So Joia, take it away.
Thank you so much, Max, and just an honor to be on this panel of esteemed and very experienced speakers, advocates, and implementers of global health programs around the world. And we've all, as Dr. Swaminathan said, and Dr. Frieden, we've been working together for many years on this. And I want to start by saying that we are, I agree, currently at this moment in a zero-sum game, as Dr. Swaminathan said. But make no mistake, scarcity is a political fiction, and it is a political choice. And the scarcity that we are facing now is because we have not had a plan from day one to vaccinate the whole world. And it makes no sense in a pandemic that we wouldn't be fighting for universal access every day. And what would that look like? It would look like 10 billion doses as the plan. And when you understand that maybe the plan for COVAX, really important effort, but was about 600 million doses, that it is not approaching what we need to give 2 shots to every eligible person in the world. And so if we really want to get out of this pandemic, because we're all in it together, whether we think we are or not, every variant is coming from an unvaccinated population with high levels of transmission. And those variants are coming whether you live in Cape Cod, Massachusetts, or Manchester, UK. They're coming to you. And so we've got to have universal access in the fight for equity. And how do we do that? Well, we have to fight against the notion of scarcity. And as Dr. Swaminathan said, we've done that before. And we've heard these arguments before. With HIV medicine, it was that there weren't enough raw materials. But what happened was once there was political commitment, the work on patents and transfer technology and money, which is what we really need, Then, magically enough of this raw material was found to now have 27 million people on HIV therapy. People will tell you there's not enough glass vials. There's not enough lipid nanoparticles. But again, this is a political choice that's being made. Just last year alone, for example, 634 billion microchips were made. Do we think for a minute that the microchip makers would just say, we just can't do it? No, they wouldn't, because they are working in a place where the market is working. But when we talk about global health and the world's poor, the market will fail unless we intervene. And the ways to intervene is transfer technology and have mass production. And so we are committed to that. And we believe at Partners in Health, and many advocates around the world believe, this is a test of our ability to collaborate in the 21st century to fight the real insecurity of this century: climate, pandemics. We cannot be nationalists and fight these things. As Dr. Frieden said, we have to be collaborative. And collaboration for us really looks like three things: breaking, sharing, patents, paying for royalties. Again, it's not that these are going to be stolen from people. Second is transferring the technology to the global south. And the third is the wealthy world financing the mass production of vaccine. And once those financial flows happen, we've seen it before, we will see it again, the glass vials will materialize, the lipid nanoparticles will materialize. And so we really believe that this global test is a test of our shared humanity and our ability to collaborate. And so we're really asking the Biden administration to take a lead in a new kind of global security that is really turning swords into plowshares and saying, what are the common tools in the common domain and the common good that we need to all be secure on this planet? And so I'm honored to be here, and I'm looking forward to more questions. But boosters are, again, part of this scarcity and political fiction. It is the moment we're in now, but it doesn't have to be the moment. The last thing I'm going to say is we were told in November of 2020 that it would take 6 months, and that was too long, to transfer technology and produce vaccines on the on the African continent. Had we started in November, we would have been producing vaccines in May. So we've got to start. We've got to start. Thank you.
Thank you. I wholeheartedly agree. And I think it's really helpful in ending to draw out the timeline here and to acknowledge not just that, this pandemic started well over 18 months ago for many people around the world, but also that these conversations that we are having today about the need to act more quickly are conversations that we have been having for just about as long as the pandemic has been with us. I'm very excited to introduce our final speaker before we get to more questions. Dr. Salim Abdool Karim is the director of the Center for the AIDS Program of Research in South Africa, CAPRISA. Among many other things, is also a member of the Physicians for Human Rights Advisory Council. Salim, over to you.
Thank you very much, Max. It's indeed a great pleasure to be here along with several of my colleagues, Dr. Swaminathan, Frieden, and Mukherjee. So let me just make 3 points, if I might, in the minutes I have. The first is that it's called a pandemic for a very specific reason, that it affects everyone, and that we in the global community are all interdependent. There is no scenario that sees one country vaccinating and controlling the epidemic while it is spreading rampantly in other parts of the world. There is no such scenario that sees us defeating a pandemic in that kind of way. We need to defeat this pandemic by dealing with it at a global level. And just to reiterate the point made so well by Dr. Mukherjee, to do that, we have to vaccinate the world. And we need a plan to vaccinate the world, because currently our vaccine distribution system is broken. It's broken because it depends on willingness and ability to pay, or it depends on your ability to seek political favor and get donations. We need a plan that is based on need, one that deals with countries, whether they are rich or poor, but ensures equity. Second point I want to make is that what's becoming very clear is that the vaccine distribution system and vaccine availability and vaccine inequity is creating a whole new category of haves and have-nots. Have vaccine, have not vaccine. That distinction between haves and have-nots that now extends us from financial abilities and money to whether you have a vaccine translates directly to availability of resources. It translates directly to your ability to go to work, your economy, your ability to travel. We have created a new division in this world. We have created it by creating a new category of haves versus have-nots. And the third point I want to make, and I say this as a member of the African Task Force for Coronavirus, I spent 3 hours this morning in 3 different Zoom calls where we are busy working on with the African CDC and the African Union on looking at how we can manufacture vaccines in Africa, because I believe that we need a short-term solution. And that short-term solution is to make vaccines equitably available. We need a second part of that is support for poorer countries with weaker health systems to take those vaccines and to put them in arms. And then the third, which is really important for me, is a medium to long-term solution, which Dr. Swaminathan touched on. The WHO plays an active role in, which is to create self-sufficiency in the medium to long term, because it's not just about COVID-19. There's another pandemic coming along. We're going to have malaria vaccines coming along. So all of that is going to need local vaccine capability. And so I see the solution that we talk about as one that needs to address the immediate challenges of vaccine distribution and vaccination coverage, but also a longer-term solution. I think if we don't do that, we can see variants that will continue to develop and spread. And variants have changed the game because they have created in us a whole new dynamic about our ability to keep this virus in check. And I think as long as we keep the haves and the have-nots, we will continue to be a slave to this virus. Thank you.
Thank you so much, Sim, and thanks again to all 4 of our speakers, and thanks to all of the media representatives who are on the line. Please continue to submit your questions, and also if you would like to ask a question directly to any of the panelists, you can use the raise hand function in Zoom. One question that came in as you all were providing your remarks from Shabtai Gold at DevEx is, what do you identify as the bottlenecks in delivering vaccines to the world's poorer nations? Is it an issue of supply, of vaccine production, a financial issue, an issue of readiness? And what are the quickest ways to get vaccines to people?
Maybe I'll start very briefly. Fundamentally, it's a supply problem. There also needs to be good planning. But if you dump vaccine on countries at the last minute without planning, without a clear way of knowing whether they're coming in the midst of regulatory questions, there may be problems with utilization. But the issue isn't primarily the ability of countries to use vaccines. We see countries all over the world having very high vaccination coverage rates, as long as they're not leftover vaccines being dumped with short expiry. But others can comment more meaningfully than I on this.
Perhaps I'll just add one point to that. I think there is a supply issue, but I think there's also an issue of several countries placed substantial advanced market commitments, and so have substantial stockpiles. And they're keeping those stockpiles because they're not sure about waning immunity, they're not sure about booster doses, they're not sure about when approvals are going to come for children. and they don't want to be found to be short at that time. So they sit on doses, they hoard the doses. So it's what Dr. Mukherjee said, it's a political decision as much as anything else. And so we have to balance that, the supply issues together with the distribution issues.
Yeah, I would just add that, there are excess supplies, and we have worked with Partners in Health, have worked with a number of countries that have said absolutely they would bend regulatory rules to get those donated vaccines, and we are unable to get them. And we don't know exactly if the US government has made other deals with these companies so that they cannot ship them out. But we know that there are expiring doses, and we've tried to move heaven and earth to get them to countries. And I'll just say, one of my colleagues, Banushka Pierre in Haiti, is a physician. She's the only intensivist in the country, and she was not vaccinated for 18 months, working alone every night. She had colleagues, but the only trained intensivist. So how that can be in a country like Haiti, which is 90 miles from Miami, this is not about regulation. This is really about the unwillingness to move vaccines, because, there are many countries that would willingly take the vaccine tomorrow. The other thing I would say is, in none of the countries that I work, which are 12 around the world, has the vaccine been as politicized as it is in the United States. So we do not anticipate the kind of hesitancy that's happened in the United States using the vaccine as a political football as it has been in our country. And so there are many people waiting for it that would use it immediately.
I can quickly add, I think a year ago, if we had thought, about the scale and the volume of what we're trying to achieve, there were a whole lot of constraints and issues that one would have thought of, and we did think of those. So working, through the Gavi Alliance, that's UNICEF, WHO, and many other partners working on the ground, we've been able to overcome many of the challenges, including the ultra cold chain that's needed for the Pfizer, particularly for the BioNTech Pfizer vaccine. And today, 85% of low-income countries have got some ultra cold chain. And this has been done for Ebola vaccine also in the past. So it can be done. Countries have shown that they're capable of doing it. There's been a lot of planning, but I think, as Dr. Frieden was saying, if there is no visibility on supplies and when to expect what doses, and suddenly you get a donation from a country of doses that will expire in a few weeks' time, it's really very difficult to then expect a country to take those and distribute them, satisfactorily and have a campaign which then goes in fits and starts, because then they're out of supplies and then they're waiting for the next set to come along. So this is what we were trying to avoid through COVAX, having all of the contracts and trying to have some sightline on how and when doses would come. But these did not happen over the summer due to a number of reasons, including, the Serum Institute of India was a major supplier to COVAX, and those doses were then, went to vaccinate the domestic population in India. So that's just one example of what happened with supply. So supply is a very big issue. In fact, it is the major issue, and all of these other things are being sorted and can be sorted. And I said, regulatory harmonization was something we did early on, because normally it takes, you go country by country. The manufacturer goes country by country trying to register a new product. And obviously this is not possible in a pandemic. So we worked with partners again to make sure that countries would accept a standard dossier. And as soon as WHO provided an emergency use listing, most regulatory authorities around the world have used the WHO's EUL to actually license the product within their own borders. So many, many innovations, which I think we must remember for the future, not just for pandemics, including the fact, as Dr. Karim was saying, malaria vaccines. There are public health diseases today which are still killing millions of people. There's no reason why we cannot learn the lessons, that we cannot, that's why it's even more important, I think, to transfer these technologies. We need to deal with all the other diseases as well that people die of because of lack of access to medicines, to monoclonal antibodies, to vaccines. Thanks.
Thank you very much, and thanks to all for your responses. And I think bringing the urgency of the moment to this very week and the events that are happening this week that have brought us together on this occasion. There's a question in from Sherry Fink of the New York Times. Anything more that each of you would like to say about your feelings and hopes for the summit, the Global COVID-19 Summit and the General Assembly? What do you see as the usefulness of events like these, and what can they or can they not accomplish? Maybe I'll turn it over to Joia to start us off there.
We would like to see funding. We want to see real transfer of technology that's meaningful with funding in a collaborative way, not unlike the Global Fund to fight AIDS, TB, and malaria, and something that really says that we are in this together.
Tom, do you want to jump in, noting that?
Yes, sorry. I think there has to be a commitment to saying the US taxpayers paid for this technology twice over, once to invent it and the second to pay for it. It's in the US interest that one small company in Cambridge with 1,600 employees is not going to be the bottleneck for massive scale-up production of a life-saving technology. And so I would like to see a commitment from not just the US, but also European governments, which funded BioNTech, to saying we're going to, while we respect the legal rights of companies, we're going to use every legal means at our disposal to break the duopoly that's holding the world hostage.
Salim?
I think the overall goal that is set, in the declaration of the summit, I think is a laudable one. The one to try and achieve 70% coverage in all countries across the globe, within a year, to me is a laudable goal, one that is achievable, one that is doable, and one for which we have the vaccine supplies for in that kind of time frame. What I would like to see accompany that is a much more detailed or practical plan of how to do that. Each country, what's their current coverage, how many vaccine doses they're going to need, where those vaccine doses are going to come from, how are they going to get it. So it's got to be, like a spreadsheet. We're going to know what's happening and what targets and how we're going to get to 70%, because it's not going to happen by accident. It's not going to happen because we willed it to happen. It's going to happen because we want it to happen and we've planned for it to happen. And I think that somebody has to be given, or some organization has to be given the power to develop that plan. And for me, the WHO is clearly, best placed to do so. The second point that I found that was really important in this declaration is that it has some good proposals to deal with some of the immediate challenges of supply. For example, one of the things specifically mentioned is about swapping delivery dates. Now, we know that several countries bought lots of vaccines. A country like Canada bought 9 doses of vaccines for each one of its citizens. So it's got a lot of vaccines that are coming to Canada, and it's got delivery dates that are sooner than COVAX's delivery dates. So what this plan suggests is swap those delivery dates. Instead of sending them to Canada, send them to COVAX so that COVAX can distribute them quickly and get them out now. So there are many practical things like that that are in this proposal. I'd like to see those happen. I'd like to see the funding behind it, and I'd like to see the planning and giving somebody the authority to deliver on it.
Soumya, as a WHO representative, do you want to come in here on what Salim has just shared, and also your expectations for commitments on Wednesday at the summit?
I agree with everything that my co-panelists have said. I would like to see all of those happen because they can all make a big difference. But I just want to add that while we're focusing on vaccines, we must not forget that there is a shortage also of diagnostics and of some of the treatments that have been proven to be effective, like the IL-6 inhibitors. They're very expensive, not available. The monoclonal antibodies are not really freely accessible. They're unaffordable except to tiny minority of people who can afford them. And there will be more treatments coming as well. They're under development. And so I hope that leaders will commit not just to making vaccines available to all, but also bringing equity in diagnostics as well as in treatments, because all of those are going to be needed if you want to save lives. Vaccine is probably the best tool, it's the tool that we need to use really effectively now, but we do need the other tools as well, because in many countries in Africa, for example, the testing rates are so low that governments really do have no idea really about the burden of the disease, about where the disease is. It's imperative that there's equity also in these other products.
Thank you all for that. And I think that's such an important point. And the initial targets released by the Biden administration do allude to other treatments as well as to testing. But again, that is, as of now, appears to be a unilateral document. And I wholeheartedly echo Slim's comments about having concrete commitments and legally binding agreements around what must be done across all of these issues, not only vaccine sharing, but also sharing technology and vaccine know-how. A question has come in from Bob Herman at Axios, which is, given the full US funding of Moderna's COVID-19 vaccine and ownership of some patents, what could the US do to increase supply specifically of the Moderna vaccine?
Well, there are a series of things that can be done. Both the US has Defense Production Authority. The US has what's called the Bayh-Dole Act, which gives it march-in rights for companies' technology. The US can fund technology transfer. The US can indemnify and work with others to indemnify. So I think fundamentally there are carrots and sticks that can be deployed. The problem is that we're off by a factor of 10 in what's being done. And incremental change is welcome. It's better than no change, but it's not what's needed. And what's needed is really a drastically expanded approach to increasing production by all of the means possible without compromising quality. And that can be done, but it's going to take being very clear with the company that it will be done, and they need to participate. And I'm focusing on Moderna because I'm based in the United States, and Moderna really owes its $165 billion market capitalization to US inventions paid for by US taxpayers. But Pfizer also has an absolute responsibility. And I have to say, not all drug companies are the same. Some pharmaceutical manufacturers understand that they benefit from public research. They benefit from public sector communications that promote vaccinations and distribute vaccines. And they have a responsibility to be good corporate citizens. Unfortunately, neither Pfizer nor Moderna is acting along those lines. Other companies have. But perhaps because they're relatively new to the vaccine space, perhaps because they're blinded by the billions of dollars that they can make out of this, perhaps because there hasn't been enough public and government pressure, perhaps because they think that it won't hurt their bottom line, they haven't so far.
Soumya, would you be willing to come in here in terms of speaking to the same question? And there's a related question around from the Associated Press around any tangible movement for tech transfer right now in mRNA technology, and what specifically would have to happen now to show a real commitment to that based on where we are right now?
So, mRNA technology, there are a lot of groups around the world that are working on this, obviously, but BioNTech and Moderna are the two companies in the lead, in the sense that they were the first to get their vaccines through clinical trials proven to be extremely safe and efficacious, and now have been widely used around the world. So there are a couple of ways in which we could do this. The technology transfer hub that we've started in South Africa, which, by the way, is meant to be a global tech transfer hub for any country that wants to start manufacturing mRNA. But of course, given there will be a lot of due diligence around that. But the fact is that one hub can train a lot of other teams. So if BioNTech, Pfizer, or Moderna were to come to us and say, we will share our technology, we will be part of your tech transfer hub. This is what we were hoping for when we put the call out in April for holders of technology to be part of our hub, was that one of the companies which has a tried and tested technology would come forward, we would establish it. And as we've all said, within 6 months, you should be able to, if you pick the right partners, experienced partners, you should be able to have vaccine production. And we could have had that by now. Now, there is another way to do this. That's a longer, slower process, because if you take a technology which is still in phase 1 or preclinical, you have to then take it through clinical development, through trials, you have to take it through licensing. All that's going to take time before you can actually scale up. So in a pandemic, that's not the ideal way to do it. We are confident that we will still have mRNA technology and vaccines being developed in the South African hub, just that it would be so much better for everyone if we had either BioNTech, Pfizer, or Moderna be a partner and share their technology. And of course, technology can improve. We want mRNA that can be stored at room temperature or in an ordinary fridge. And those things are actually being developed on the bench. But for now, we could really use these technologies. So that's what I would love to see.
Yeah, thank you. It's such an important point, and I think the timeline is so important as well, given the urgency of everything we're talking about, and the reality that a hub exists and is prepared to do the work, and in fact is going to move ahead with work, but that is going to take so much longer than it would were it not for the without the cooperation of these companies. Joia?
Yeah, can I just jump in and answer one of the other questions on the chat, and that it's similar about what we would like to see. There is hand-wringing about this 100 million doses or this, 50,000 doses or so. We have to, what we want to see is for the world leaders to come together, listen to public health experts, look at the data we have from places where the prevalence is going down, where vaccination is higher, do the math and say, what will it take? It will take, in our estimation, 10 billion doses or perhaps more if we're going to vaccinate children, which now it looks like might be the right thing to do. And then to say, what would that cost? How many factories do we need? How much raw material do we need? And work toward that as a goal. I mean, this is not a kind of, every time there's a discussion about, boosters, or these are distractions from the real problem, which is we do not have a global plan to get out of this pandemic quickly. And so that is what we would like to see, is a level of planning that matches the scale of this once in 100-year pandemic, that matches the scale of the emergency, that matches the threat of global famine, economic downturn. And we just don't see that urgency coming from the collaboration of the richest countries in the world.
Thank you for that, Joia. There is a question that is specific to South Africa, so maybe I'll direct it to you, Salim. It's from Politico. As a middle-income country, how hard has it been for South Africa to secure vaccines? We've talked a lot about the lowest-income countries only having 0.4% of all of the world's vaccines to date. How hard has it been in South Africa?
Sure, Max. I actually answered the question in text. I wrote an answer, but I think I can just summarize it to say that, we really struggled. We just couldn't lay our hands on any doses. Eventually in February, late February, early March, we secured 500,000 doses from J&J under a research protocol for implementation under phase 3B protocol, just to get our healthcare workers vaccinated. And so that's what we did. Our first doses of a licensed vaccine became available in May through a bilateral deal we had with Pfizer. And now since then, we bought several million doses from Pfizer, and now we've been getting our supply, so we don't have a problem any longer. But I think the question actually is begging a bigger question, which is, if you're going to have a plan to vaccinate the world, you have to have that plan that's going to fit in with understanding the supply and the demand and the way to get from supply to demand. You can't have a plan if the suppliers are busy making their own deals, and they're busy cutting deals with different people to give vaccines to X and Y, swapping delivery dates and so on their own, in an independent, disorganized kind of way. So we have to fix a broader problem about ensuring that there's some agreement by the pharmaceutical sector to, they can make their private deals for part of what they manufacture, but let's say some fraction, half of all they manufacture, goes into a central pot and distributed based on need. They still get paid. This is not charity they're being asked to provide. They're just being asked to provide the doses in a way that the distribution timelines are more equitable. So in Africa, we have secured 400 million doses, but they're only coming next year. So what does that mean? We're going to have to withstand a fourth wave at the end of this year. And that's going to destroy economies. It's going to create political instability, because people are going to watch the rest of the world. They're going to soccer matches and they're having their activities while we're withstanding waves in Africa. So it's going to be quite a complicated creating a two-world scenario. And I think that we've got to avoid that problem by addressing the fundamentals of the way in which we can coordinate supply and demand to achieve what the Biden summit is planning, which is 70% coverage in a year from now.
Thank you for that, Salim. And I think that that's actually a very powerful way to end this as we're coming up on time. I'm really grateful for all four of you for sharing your thoughts and your expertise today. I think the comment that Salim makes about creating two different worlds, and thinking back to what Joia said earlier, that there aren't actually two different worlds in this pandemic. We are all threatened by the continued circulation of this virus, of variants of this virus. This is fundamentally not a nationalist issue. This is a global issue. There is a global summit this week. There is the General Assembly, which is by definition a global event, and we need to take a much more equitable global approach to vaccine access if we're going to see the end of the pandemic. And we have very clearly heard from our speakers today how exactly to do that. So thank you all so much for that. Thanks to all of the press who has joined us today. If we were unable to get to your question either in the conversation or in written response, we will do so later today. And I also want to remind folks that all of this has been recorded and that the video and transcript will be available at the PHR website. And if you want to talk more with any of our speakers or with Physicians for Human Rights, you can always email media@phr.org. So thank you again for joining us today, and a special thanks to our speakers, to Soumya, to Salim, to Joia, and to Tom. Thank you all very, very much, and talk soon.
Thank you.
Thank you.